Hello, I'm Bill Lees. I'm a professor of radiology at University College London, and I work at University College Hospital in London. I've been doing ultrasound since 1974, and I'm going to talk to you about contrast ultrasound in the abdomen. Ultrasound contrast is licensed in the UK, and I'm going to show you how we use it in our regular clinical practice. Contrast-enhanced ultrasound in the abdomen. One of the things we've discovered in using contrast over the last 15 years is that ultrasound is inherently nonlinear. Many of you will be familiar with tissue harmonic imaging, where the property of ultrasound that various frequencies do not travel at the same speed through tissues leads to the generation of harmonics within the tissues, which are radiated back from the tissues to the transducer, giving us different frequencies to the ones that were actually input into the tissues to start with. It's a bit like the same phenomenon of a wave as it approaches the shore. That wave gets steeper and steeper, and eventually the wave breaks and creates noise. Those are the harmonics that we're imaging in tissue harmonic imaging. It's an inherently nonlinear system, and that's important to remember. We use this for contrast imaging today using the technique of pulse inversion, where in a perfect system, if we take an acoustic pulse, here echo number 1, and then input a second pulse, which is exactly 180 degrees out of phase from the first one, if we add those together, then we get absolutely no signal returned. They cancel each other out perfectly. And we use this with contrast imaging to suppress the background echoes from normal tissues. In the case where we have harmonics generated by the bubbles or within the tissues, this summation process does not work perfectly, and we're left, having cancelled out the tissue signal, with harmonic signal enhancement, which is coming purely from the contrast agent itself, from the bubble. And it's exploiting the nonlinear property of the bubble, that it does not reflect the sound that was input, but harmonics and other signals generated by vibration within the bubble itself. This has been extended into techniques varying from manufacturer to manufacturer. One is called power pulse inversion, where instead of just using 2 pulses to cancel out the signal, multiple pulses are put in, which can also correct for tissue motion. And these are displayed as a color overlay with the fundamental tissue image behind. Here's an example. You can see multiple signals put in, all at slightly different phases. When they're summed from the tissues, even moving tissues, the background signal is suppressed, so that all we're left with is signal from the contrast agent itself. So here's an example where we're superimposing the contrast signal over the B-mode image and showing with very, very high contrast a small lesion here deep within the liver. Ultrasound contrast agents are all very similar. They're stabilized microbubbles. The optimal microbubble size is 1 to 3 microns in size. If you think of a red blood cell, is 7 microns in size. So these are significantly smaller than a red blood cell. They can pass through the pulmonary circulation, so they can be given by intravenous injection rather than intraarterial injection, and then supply the whole of the systemic circulation. But being of the same order of size as a red blood cell, they don't escape through the vascular endothelium into the extracellular fluid compartment. They're confined purely within the vascular space. They are blood pool agents. The microbubble structure usually consists of a phospholipid shell, initially containing air in the first generation of contrast agents, but now they contain fluorocarbons and similar compounds which are more stable gases which don't dissolve readily in the serum and persist within the circulation for a number of minutes, up to 10 or 15 minutes with some of the later agents. There are a number of different agents available in the market. You can see here, and again, an example of red blood cells with the microbubble contrast agents scattered throughout them. Typically there'd be a ratio of about 1 contrast bubble to 100 red blood cells, and this is enough to get a signal from the blood pool. We can image a single bubble under optimal conditions. There are a number of different agents which have different compositions. The first generation of contrast agents were operating at a high mechanical index, often with bursting of the bubbles to produce the harmonic signals. The current agents are sufficiently stable that we can image them at very low power, which is low mechanical index, and we can scan them for long periods of time without destroying the bubbles. And we can visualize them in different phases, just like in CT or MR contrast studies, with an arterial and portal venous phase, and even a late parenchymal phase, where we're looking at bubbles that are trapped within the microvasculature of the tissue, which is a unique property of ultrasound contrast, something that we can't do with CT or MR contrast agents currently. So if we look at the microbubble, when it's insonated with an acoustic wave with a positive pressure and a negative pressure phase, the typical waveform of a longitudinal acoustic wave, in the high pressure phase, the bubble is compressed to a very small size, and in the low pressure phase, it will expand quite dramatically to a much larger phase, much larger size. And these bubbles will vibrate during this process, and it's this vibration which generates the signal harmonics that we're imaging to obtain the characteristic signal that comes purely from the microbubble itself. So here we see the nice clean input signal. This is the appearance of the signal plus the harmonics. When this is Fourier transformed, we get the various harmonic signals generated. Here's the fundamental frequency. This is the subharmonic at half the frequency, twice the frequency, 3 times, and so on. And we can separate out these signals using filtering techniques really very effectively today. So at low mechanical index, this can be anything from 0.01 to 0.2, compared with the normal mechanical index of an ultrasound scan, which is the order of 1 to 1.5. The bubbles are preserved, so we can use real-time scanning. We do need a sophisticated ultrasound machine to do this, but these are plentiful in this current day and age. At high mechanical index, for example 1.2, so the normal standard ultrasound imaging power, the bubbles will burst. These produce a very bright flash of an echo as each individual bursts, which is very easy to see, even on quite basic equipment, but we need to use special intermittent scanning techniques, having burst the bubbles, as we wait for the bubbles to replenish. This in itself can be a useful property. If we purge the image field from bubbles, as the bubbles come back into the field from outside and replenish, we're actually visualizing perfusion at the tissue level, which is again another unique property of ultrasound contrast agents. High mechanical index gives us only limited views per injection. Obviously the technique of scanning is quite difficult, and currently the first generation agent Levavist, which is still licensed in Europe and most of the world, is the optimal agent for this bubble bursting technique, but it's been superseded by the second and third generation agents such as Sonoview, Definity, Sonozoid, and so on. There are many that are licensed in some countries, many not licensed in the continental United States. So how do I use ultrasound contrast within the abdomen in my day-to-day practice, where I'm using fully licensed contrast agents. In the liver, the main use is in focal liver lesions. Obviously, detection, we can use contrast agents just as we do in CT or MRI to improve our detection of metastases and primary liver lesions. If we pick up liver lesions on a conventional ultrasound, either in a screening context or as incidental findings, we would like to be able to characterize those lesions without having to go on to do CT or MR scans. So if we can do as well with ultrasound contrast as we can with these other techniques, then we can save significant sums of money. One of the important things in planning surgery or radiofrequency ablation is to determine the exact number, position and extent of the liver tumors so we can plan our therapeutic procedures. And also we can use contrast agents to evaluate before we do ablation procedures, to monitor the ablation procedure itself and to follow up the result of ablation. And this is quite routine in my practice in my hospital, where we're doing 7 or 8 radiofrequency ablations each week. And there may well be a role in patients with diffuse liver disease such as cirrhosis or HCV and HBV infection, where we can screen the liver more effectively for early detection of primary hepatocellular carcinoma. Now, if we're looking for lesions such as hepatocellular carcinoma, as you will know from CT and MR imaging, we're looking very much for the vascular characteristics of these particular lesions. As you know, a hepatocellular carcinoma will tend to show a strong enhancement in the arterial phase with early washout in the portal venous phase. And this is due to a fundamental property of the liver with its dual arterial and portal venous blood supply, and the transformation of normal liver tissue to tumor tissue involves the progressive switching of blood supply into the pure arterial phase and away from portal venous supply. And this is progressive. As we go through from normal liver to a regenerative nodule, we have the normal balance between arterial and portal venous supply, with perhaps 70% of the normal liver tissue being supplied from the portal venous circuit. We go through dysplastic nodules, we gradually introduce an abnormal arterial supply, and as we go through progressively more malignant lesions from well-differentiated to poorly differentiated HCC, in the end this transformation is complete, and the poorly differentiated HCC will derive its entire blood supply from an abnormal arterial circuit and almost none from the portal circuit. This property was used extensively in the early days of CT, where we were doing CT angiography using direct hepatic artery injection of contrast, and then portal venous imaging using injection of the superior mesenteric artery to fill the portal circuit after circulation through the intestines. And it was shown very elegantly back then that these lesions, even quite small lesions, if they were truly malignant, derived almost their entire blood supply from the hepatic arterial circuit with minimal supply from the portal venous circuit. This involved arterial cannulation when transferred to the CT scanner and rather fell out of favor. And we can get almost as much information today with modern CT scanners from a rapid intravenous bolus, although there is some blurring between the two, the arterial and portal venous phases, but with practice diagnostically we can do almost as well. Interestingly, the CT arterial portography is coming back into fashion, where particularly interventional radiologists in the Far East are working with hybrid systems, combined angiography and CT systems, particularly where they're performing super selective embolization and chemoembolization. So this technique hasn't gone entirely out of fashion. It is coming back quite well. Now that property can be visualized using ultrasound contrast agents almost as well. Here's an example of a large 4 centimeter HCC within the right lobe of the liver, visualized by conventional B-mode imaging. Here is the arterial phase of an ultrasound contrast study given by intravenous injection. We can see the feeding vessel here into the tumor with large vessels in the center of the tumor and a very strong arterial phase enhancement with minimal enhancement of the lung parenchyma around. Fairly characteristic features of an HCC. And here we can see the same sequence again with the conventional B-mode image before contrast injection, strong arterial phase enhancement, here with some central necrosis, and here you can see what is called early washout, where in the portal venous phase, at about 60 seconds after the intravenous injection, we have relatively poor enhancement of the tumor with strong enhancement of the surrounding normal liver parenchyma. According to the criteria of the European Association for Study of the Liver, visualization of this classic pattern is sufficient to diagnose a hepatocellular carcinoma without the need for biopsy. We can also use the same techniques for diagnosis of very small metastases. This is a colorectal liver metastasis. It's about 1 centimeter in diameter, here in the portal venous phase, and we can see good enhancement of the normal liver parenchyma around with very high contrast ratios between the tumor and the surrounding normal liver. This is the corresponding CT scan where we can see this small tumor which has an enhancing halo. We're more in the arterial phase here than in the portal venous phase, but you see exactly the same temporal characteristics with contrast ultrasound as you do with CT. We can also have some interesting observations in chronic liver disease. Here is a patient with cirrhosis with nodule formation that on the basic B-mode image we can see a rather diffuse nodular pattern. After administration of contrast and viewing in the delayed phase, we can see that this nodular pattern has been enhanced, and we can see much more clearly the individual nodules, their size and size variation that go up to make the standard cirrhotic pattern. So we can use this in diffuse liver disease not only for detecting malignant focal lesions, but also for enhancing the pattern of nodule formation. Some people have used contrast to look at physiological parameters, and one of these is the mean hepatic transit time, where one is looking at the difference in time between the arrival of contrast in the hepatic artery and portal vein to the arrival of contrast in the hepatic veins. And it's been known for many years that this is shortened in cirrhosis, where patients have a hyperdynamic circulation. This actually compares two different contrast agents, but it does show that it is possible to obtain physiological information, if that's what you're interested in, by using contrast agents. We have used high MI imaging using the first generation contrast agent Levervist for studying other types of tumor within the liver, particularly Klatskin tumors or hilar cholangiocarcinomas, which can be extremely difficult to see by conventional ultrasound, by CT or MRI scanning. This is using the delayed high power high mechanical index technique, and you can see here an abnormal texture in the central portion of the liver on the pre-contrast scan, but here looking in the delayed phase after contrast, we can very clearly demonstrate the full extent of this malignant process within the central part of the liver. Here's another example showing very clear delineation not only of the full extent of the tumor at the hilum of the liver, but looking at the very sharp boundary that this tumour presents, we can see whether or not there is direct invasion into the surrounding liver parenchyma or merely a simple mass effect. You can get the same information occasionally from CT scanning. Here's an example of a nice 3D study where we have particularly clear visualization of the tumour mass at the hilum of the liver, but this is unusual for CT, and what we've found in our studies of this process that the ultrasound contrast technique is as effective as the best technique we otherwise have, which is MRI, and significantly better than CT scanning at demonstrating the presence of a mass, at demonstrating the size of a mass, and at demonstrating the extent of invasion into the surrounding liver parenchyma. Very often the clearest images are obtained by ultrasound contrast rather than by CT or MRI, though each have their own particular advantages. Now, there have been a number of studies done in Europe and in Asia using ultrasound contrast looking for liver metastases. This is a study in which I took part looking at the first generation agent and comparing with spiral CT. And what this study shows is that the pulse inversion contrast imaging at ultrasound is significantly better than conventional ultrasound, showing many, many more lesions, and is also capable of performing almost identically to what was then state-of-the-art CT imaging. Obviously, CT imaging has improved since then, but so has the ultrasound contrast imaging. So as is typical in radiology, all our imaging techniques improve in concert and remain equally competitive at all times. And there are many studies that have confirmed this. Contrast ultrasound is at least as good as CT scanning and is probably nearly as good as MR scanning in the liver. Now, one of the important areas in the liver that we need to establish, particularly in patients with colorectal cancer liver metastases, is the presence of very small lesions or satellite lesions. And this is what I mean by a satellite lesion. Here is a large colorectal cancer which has been surgically excised, and here you can see a sub-centimeter lesion. It is about 1 to 2 centimeters away from the main tumor mass. And colorectal cancer metastases spread through the liver largely by invasion of the vascular spaces and can grow along blood vessels and appear as separate metastases within this halo of 2 or 3 centimeters around the main mass. This has always been the reasoning behind the surgical dictum that if you excise a colorectal cancer metastasis, you must take at least a centimeter of normal tissue as a safety margin so that you gather in these often microscopic satellite tumors. And we know that CT and MRI are not very good at picking up sub-centimeter lesions because the inherent contrast is insufficiently great. Here we can see in the same patient a satellite metastasis, again well under a centimeter. This is about 5 millimeters in diameter. We can see again it's about a centimeter away from the primary tumor, and we can see exactly where this is in relation to the primary tumor. So it's obviously important to remove or ablate this lesion as well as the primary tumor mass. Here's a second distant metastasis. Again, you can see the very high contrast that we have in contrast ultrasound between the poorly enhancing tumor and the surrounding normal liver. So we can be quite confident in diagnosis of lesions down to about 5 millimeters in diameter. There are various different modes for displaying the ultrasound contrast result. Here's another metastasis, about 2 centimeters in diameter. Again, note the very high contrast ratio between the tumor and the surrounding enhancing normal liver. This also applies to looking at the periphery of individual tumors. And one of the features we've noticed with colorectal cancer metastases with CT is that we often have arterial phase enhancement on the periphery of the lesion rather than the center, and we can see this pattern of these separate tumor nodules growing out or budding out from the main tumor mass very clearly with contrast ultrasound. And this type of pattern has been associated with a poor prognosis. If you look at the basic B-mode image, those of you who are experienced in ultrasound will recognize that there's obviously an abnormality there, but the clarity of definition of that mass is dramatically better with the contrast ultrasound. Here's another example of a paper published in 2003, where we can see contrast in ultrasound shows more metastases than CT, and in patients who've had other standard reference imaging techniques such as MRI, intraoperative ultrasound, or examination of implanted livers, CT does not perform as well as ultrasound. And there are many papers to confirm this now. So contrast ultrasound in detecting metastases is as good as MRI. It's better than CT scanning. Another example showing demonstration of sub-centimeter lesions in relation to a large metastasis with an enhancing rim. Very clear definition, very important for surgical planning. So that's detection. It works. Characterization of liver lesions. Well, the principles on which we work are very similar to those of contrast studies at CT and MRI. This is a study again from 2002 using the high mechanical index technique, which was all we had in those days, trying to compare the properties of benign and malignant lesions, and we can see that homogeneity on the late phase is typically benign, no late phase enhancement is typically malignant, and so on. Here's some examples. Again, an obvious metastasis, very clearly seen. Here's a tiny metastasis seen on the periphery of the liver, which is less well defined as CT equivalent. Lesions such as focal nodular hyperplasia do show characteristic features, and typically they will show strong lesion uptake of contrast and late phase imaging, which we don't see in the typical malignant lesions. And in many cases, it's possible to see the scar, the central scar of focal nodular hyperplasia, which the pathologists tell us is always present, but it may be no more than a millimeter or so in thickness. So here's an example of focal nodular hyperplasia, not much to see on the conventional ultrasound image. Here's the central scar visualized in the arterial phase of this FNH. If you see the central scar, you can be very confident in your diagnosis. The temporal enhancement pattern also lends to significant confidence. Being able to characterize hemangiomas at the time of the original ultrasound scan is important and can save considerable costs. Typically, we will see characteristic globular enhancement on the periphery in the arterial phase, and this is particularly true when we're dealing with larger lesions, which we are much more likely to classify as atypical from their morphological characteristics. Small lesions we can usually characterize very well just on their morphology. It's the atypical lesions that are more difficult. Here's an example. Here's a 5 centimeter diameter hemangioma. Its characteristics are not typical morphologically. It's not particularly echogenic or well defined. Here, after administration of contrast, we can see the absolutely classical nodular peripheral enhancement that we're used to seeing at CT. We can say with great confidence that this is a hemangioma and requires no further attention. The low mechanical index technique gives us a much greater opportunity to study blood flow during the different phases. In fact, we can scan continuously for several minutes through the volume of a tumor, and hence we're not looking at phases but a complete dynamic examination. So The other factor that's important with the low MI technique, if you go back to one of my original slides, the tissue harmonics that are generated by the passage of an ultrasound pulse through the tissue are reduced at low power. They're really a function of high power imaging. So we still retain the bubble harmonics, however, so we get a better signal to noise ratio at low power than high power, which is completely unlike CT or even MRI. So at low MI imaging, the initial phases emulate dynamic CT. We're looking at arterial and portal venous imaging, but the late phases, the bubbles are retained in the microvasculature, and this is closer to the kind of reticular endothelial imaging we will do in the liver using specific ultrasound, MRI contrast agents such as SPEO. And the agent that is licensed in Europe for this type of imaging currently is the agent SonoView, which is the most widely used agent in Europe at the present time. And we use this almost exclusively in this low mechanical index imaging mode. Here's an example in the early vascular phase. We can see we're visualizing the individual large vessels particularly well, showing no enhancement in this malignant tumor. Here's another example of later phase imaging where we can see again the microvasculature of the tissues with very poor microvascular filling in the tumor itself. Because the technique is very sensitive to very small lesions, here's an example of a patient planned for surgery for resection of metastases, and we can see in this CT scan multiple enhancing lesions down to a few millimeters in diameter. Now, this is an exceptional CT scan. We will only get this kind of image quality possibly only for a few seconds during one part of the arterial phase. And in CT now we divide it up into early and late arterial phases, but we can never predict exactly which point in time will give us the best image. With the ultrasound contrast we can detect these lesions equally well, but by continuous scanning we're less temporally rigid than we are with CT. One of the factors that enables us to perform treatment so effectively in the liver is the use of contrast. Here, for example, is an HCC immediately after radiofrequency ablation, where we can see a fairly poor definition of the tumor. Here on CT, we can see preservation of a small area of enhancement indicating residual tumor. We can use this quite effectively with ultrasound contrast to control the effectiveness of our radiofrequency ablation and pick up quite small nodular areas and determine whether or not there is residual tumor which we need to go back and to treat. So in my practice now, ultrasound contrast is fairly routine in liver imaging, wherever we're trying to detect or characterize focal liver lesions, and particularly for controlling biopsy or radiofrequency ablation techniques. We can use it in the pancreas as well. And here is an example of exquisite visualization of a pancreatic tumor. This is the corresponding MRI slice where we don't see the tumor anything like as effectively. You can see on the MRI there is some thickening of the duodenal wall. Here we see it on the contrast-enhanced ultrasound. This is the mucosa of the duodenum. You can see the layered pattern, which is enhanced normally. And this is poorly enhancing tumor invading the muscularis propria of the duodenum in almost a circumferential pattern. So we're seeing that really well, both anteriorly and posterior to the tumor. But here's the key finding on this scan. We can see a tiny tongue of tumor here growing out towards the enhancing superior mesenteric vein. And this ability to show the relationship of the tumor to the portal vein is vital in planning the type of surgery that we're going to perform for primary pancreatic tumours. And in studies to date, ultrasound contrast has performed at least as well as CT and MRI in staging primary pancreatic carcinoma and determining the vascular relations and degree of vascular involvement. Now, there's a large number of different research opportunities with ultrasound contrast, particularly when we're trying to study animal models. And one of the things that properties of ultrasound is that it can be scaled up or down very effectively in a way that is more difficult to do with CT or MRI. In our small animal imaging laboratories, we do have micro CT and micro MR scanners for studying small animal models, but these are extremely expensive. Yeah, ultrasound can be scaled down by increasing frequencies and by building special transducers. And here, for instance, you can see a Doppler study of a 2 millimeter tumor in a mouse, where we can enhance the Doppler study by contrast to pick up what is really microvasculature within the tumor and study the effects of things like anti-angiogenesis agents and see their immediate effect on tumor blood flow. Here you can see a mouse heart being studied with ultrasound. The mouse heart beats at between 300 and 600 beats per minute. This is far too fast to be visualized by CT or MRI, but ultrasound, on this scale at least, which is less than a centimeter, has the ability to keep up with these incredibly high frame rates, and ultrasound contrast, as you see here, will not only demonstrate for us the chambers, but here you see bubble bursting, a high mechanical index pulse to purge the myocardium of bubbles. You can then look for reperfusion, and there you can see it occurring even on this millimeter scale. And this is translated into myocardial perfusion studies in man, where we can demonstrate the extent of infarcts really very effectively. We can also image selectively the microvasculature. If we're looking in the late phase, after the initial arterial input, bubbles get trapped in the small capillaries and microvessels of a tumor and will very slowly pass through. In any individual scan snapshot, we may visualize a few of these small microbubbles, but we don't get a picture of the microvasculature as a whole. But if we have a very long persistence mode and some images in sequence, we can build up a gradual image of the full extent of the microvasculature. Here you can see the tumor, a necrotic center, and multiple feeding and draining vessels in this small breast cancer. And this technique of microvascular imaging, or MVI, as some of the manufacturers call it, is extremely powerful in imaging structures such as the breast and the prostate. It can be applied to larger lesions in the liver, again looking at late phase imaging, looking at the smaller numbers of microbubbles as they slowly traverse the lesion, so we can build up a pattern of both small and large blood vessels within the tumor and see exactly what is happening. So now, using these techniques, we're able to visualize with contrast ultrasound blood vessels of the order of 50 microns in size. And it's at this level of scale that we start to see the abnormal patterns of the microvasculature, which is tangled, chaotic development of vessels with blind-ending vessels, shunts, loops, and arcades that we don't see in the normal regular pattern of normal tissues, such as here in this renal cortex. So certainly, at least with animal models and with superficial structures, using very high frequency ultrasound imaging, we are now able to visualize a microvasculature. We can also perform perfusion imaging. If we give a high mechanical index pulse to burst all the bubbles will slowly perfuse into the imaging space from vessels around. And we can map regions of interest, and we can plot the arrival of these microbubbles with low mechanical index imaging and produce graphs of this type that you'll be familiar with from dynamic contrast-enhanced CT and MRI. And from these curves, we can derive numbers that will tell us how well perfused particular pieces of tissue are. We can derive perfusion maps or individual point perfusion profiles. This is also very useful in cardiology as well as in imaging of tumors in animal models and superficial structures. Now, there are a number of other applications of contrast-enhanced ultrasound that I don't have time to talk about. They can be used very effectively in renal imaging to look at tumors and characterize them, and also distinguish to a certain extent benign from malignant small renal tumors at least as effectively as we can with CT. But they can also be used very effectively for vascular imaging. They can be used to show leaks for endovascular aortic repair. You can detect pseudoaneurysms in pancreatitis very effectively. And you can even track acute bleeding from liver and spleen and abdominal trauma and show exactly where the bleeding point is. In fact, I've even treated a few bleeding lesions by direct injection of thrombin and fibrin tissue glue, having located the site of bleeding using contrast-enhanced ultrasound. So just as with CT, you wouldn't perform an abdominal CT without the use of contrast. Certainly we're getting close to the point where with ultrasound, if we have significant lesions or significant pathology to investigate, contrast-enhanced ultrasound is equally important as contrast in CT. But the research possibilities are continuing to grow. We've had difficulties until recently applying ultrasound contrast techniques to organs such as the prostate, partly because the high frequencies that we use for prostate imaging are not really compatible with the microbubbles that are available, but different size microbubbles, different composition microbubbles respond differently to different frequencies, and we're gradually learning how to do this. And we can plot different parameters, such as arrival time of contrast in various points of tissue, and draw maps of the prostate, here showing that in this obvious small prostate cancer, we can see an early arrival time of contrast in the bulk of the tumor compared to the rest of the prostate. And this is important when we try to evaluate the effects of different therapies, medical therapies, on prostate tumors, such as anti-angiogenesis agents or anti-androgen therapies. Here is a simple power Doppler study of the prostate, enhanced by contrast to give us better visualization of the degree of vasculature. After several weeks of anti-androgen therapy, you can see that the vasculature declines dramatically, and a switching off of blood flow through the malignant areas is a characteristic feature of successful treatment of prostate cancer. So in Europe now, contrast-enhanced ultrasound is becoming a fairly standard technique for the evaluation of significant abdominal pathology, but is also forming a bigger and bigger part of research programs, particularly in oncology, particularly in the search for surrogate markers for the immediate effectiveness of new drug therapies. Thank you.